you hear me, Janet?
Yes.
Oh, wait, hold on. Can you hear me now?
Yes.
Can you hear me now?
Yep.
Can you hear me now?
Yep.
Wait, sorry. Can you hear me now?
Yes.
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 Oh, okay. Uh, I want to see. Hmm. Uh, okay, I'm gonna ask you a question. Can you just type in the chat because I'm gonna mute my volume because
Okay.
so like so people when they type in like in the morning they can't it doesn't do that bang off. So uh, I'm gonna talk and then just type in the chat if you can hear me.
Okay.
Can you hear me now? Oh, sweet. Great. Okay, this works then. All right. So I'm muting myself. The mic is on. Fantastic. Thank you. Morning.
Morning. Hello.
Decisions.
Yeah, good to see you.
Did go to. Yes. There's some leaves out there.
Oh, boy. And down my phone. This history, almost. There are 8 months that are just. That is. I wish we could do. Back in the stuff. We fun.
I picked actually driving up from back. When I leave here, when I work here, I up to. Seventh Street line. And right up from that. And, yeah, that wall, they.
Well, that's
It's a video this year, but
yeah.
I sent it to some friends that I do some product once a week. Because it really is, it's right.
We've seen them for over 30 years, but this is that's my number.
Well, part of the problem is that that we start to appreciate the all colors need to be found. It's like,
Sorry. I'm proud
right? So I remember.
I'm getting over the problem.
I remember. Yeah, as
Not very good.
a doctor, maybe 30, 32 years of age. That patients were in clinic. I'm gonna do this, fall. Well, we're gonna go to the northeast and see the colors. I'm thinking, why in the world?
Yeah.
Fly to.
Just going up to our house.
Just to look at, just look at these.
Photos.
Yeah, so I mean, so that you appreciate it. That.
So we're from that spring.
So we live, actually just to go, we probably part of the stuff that's in our house. We actually live, we built Ridgemont, the same 8th Street Road, but Ridgemont, so Somerset Road. We're not there, we have to go to Cliffview, which is little tennis courts on. But just turned around, there's a spot. So we live there, so in that zone. If we can go to that. You turn left with Marshall Priest's house used to be on the right. To his house is out.
Yeah.
So we just got a little bit.
So if I'm going up, Richmond, I'm 20.
You're left at the tennis court, some, not our tennis court, they go to south. Excellent. So you turn left and make the right, just down the street. Used to be the place, used to be in the old days when doctors doing hospitals and patients, hospitals and programs. Those kind of close by to the seconds and some people were good. I'm on that way out. Get to the ER.
So we moved here in 1980. And we were looking here, that's what this was really going to do. State house provided real estate for some, we had a show for that. She took us up but and I filled with that school. She can't afford it. I was just thinking I would make it.
Yeah.
She knew nothing, right? Basically. And so told it, so we ended up late Jordan.
Yes, we were back for a year.
Was talking
Yes,
to Gorden.
What's that? We just talked to this
morning.
I don't know, man.
Every once in a while, we would try to find
It's back here.
that house,
Yeah.
but unless you know exactly where you're going, sure, we're talking. All right,
What are you doing?
so. 1991. I was pretending to do that at all, so I was down to the driving. Anyway, I got home.
I'm expecting to stand in remotely. I don't know about you.
Dude, that's what I'm expecting. FYI, I started recording.
Now we had inspection. We got up there, get there about 5 foot. Real estate person was, not really. Yeah, I had a old car at that point and I was not dressed really well. But anyway, so we said, okay, And so she took the same, went into the. beach.
Yeah, most people did it around that right here, because like she did hospitals.
And she had no issue. And so we parked that car and went back and so we're standing just like, they could not. And basically, yeah, and I cleared our check hour.
So, could the answer slide,
And,
and then with the bands go back and later. So what I would do first is pointing at the wall. And then, yeah, because like, other, they're like, you can't see it, like the wall.
Friday. Well, we're going around home, having a good sized house for almost all the time. After a few years. We're able to do that today. I'm feeling that market is exactly what.
No hard questions, please.
With that, finish that conversation, we called the realtor and show us around and help us with our restaurant. Yeah, as the real estate, these are the kinds of houses.
Yeah.
She's come.
She'll be
You too. Well, they now, I want to bring get free around. I need to go and eat brand.
Well, actually, so maybe look like that's what I'm starting.
That's a noun, I just want to get this, and then, everyone.
So you probably run into, Randy Henry. Which is good time is right, but he's not been involved in.
Fine.
Come down to those, maybe. Other areas.
I've heard the name, but I can't put a face to it.
I guess at the winter conference coming up.
Yeah, Jen.
I always think it was earlier, but okay, after the new year.
Yeah.
Okay.
That's fine.
How did they get you? So who reached out to you to do the presentation?
It was a good.
Tanya?
I don't remember. Huh.
You volunteered,
Showed up, yeah.
just like, so I'll do this.
Maybe I wasn't invited, I just showed up and.
Assume you were Dr. Gordon?
Yeah.
Hi, I'm grandmother. Very nice to meet you. I'm a retired cardiologist. I saw what this was about, and you can see me anywhere. That sounds really getting up early.
A whole bit's worth of time.
I'll report back. It's not.
I've worked in it.
We should have found the clinic for you.
You know, there's some seats up front.
We're the headquarters. No, we're the headquarters in the back. We're the kids in the back.
Glad I said I'm good.
Dr. Coxon's working on her rebuttals here.
Yeah, I figure.
Yeah.
Yeah.
Yeah, so we did, but I don't.
That's. Got down something. I really want to do my.
No, you're so.
You know, it's like.
Here. I should really just.
No, I'm not good.
So I just.
I can't even imagine.
Yeah. And I was like, I think it was the calendar. Oh, yeah. For vaccine. Yeah, that's how I.
What are you saying?
I don't know what's happening.
Absolutely like me.
How much are your?
Yeah, I've never told me.
Very. Yeah. Are you yeah. Like I'm
Yeah, I can tell you. Yeah. When you show. Lessons for a year. In the last 2 years, I've been taking.
Yeah.
I don't do it anymore.
They're very flexible right around.
Good morning, everyone. Today we have Dr. Nick Gorden. He practices medical oncology and hematology at Boise, PA, where he's clinical faculty at the University of Washington School of Medicine Laney program. He attended medical school at the University of Washington. Then he left for training to Colorado, where he completed internal medicine and hem-onc fellowship at the University of Colorado. He is interested in malignant melanoma and molecular profiling and precision oncology. That's for Dr. Gorden.
And per your expectations. Good morning. Thanks, Dr. Vo. Thanks for inviting me to come give a talk. Kind of more on past history. I did have a brief career doing more bench work and those molecular profiling of a hindbrain malformation, and very rewarding where you can actually see a disease, do some mass parallel sequencing, next-gen sequencing, find those causes very quickly. It kind of devolved from there, interest in melanoma, looking for those same kind of risk factors and realizing there's a lot more going on than a single gene to explain what's happening. And actually had a similar research focus on multiple primary melanomas, now expanding out to all malignancies. And we'll see, we're a bit limited here. We have a lot of retrospective data, a lot of cohort data, but very hard to understand what's exactly triggering patients with these multiple primaries. I do not have any pertinent disclosures. Maybe someday I will, and I'll retire. We'll go over some objectives. So we'll talk about these MPMs or multiple primary malignancies. Talk about risk factors with kind of a specific focus on our veteran population. We have a lot of anecdotes what we see here, but see if there's anything we can find to kind of explain why we're seeing them and seeing them so often. And then we'll talk a little bit about management and what we do with them after we find these cancers. First, I want to start with a case, kind of highlight some of these patients with these multiple primary malignancies. Patient we have here started her journey now about 4 years ago. So 69 just came into us with kind of something stuck in the back of her throat. Up to swallowing, couldn't quite clear things. Past medical history, didn't give us too much there. Let's look at her exposures and military experience. Air Force, was a smoker, also had some time getting some possible radiation as a radiation technologist. Family didn't give us any hints, didn't have a family history or anything that raised our eyes to go, oh, there's something that could be here. Axial imaging, the head and neck, revealed by the arrow sign there, a kind of large enhancing mass on the left oral pharynx, kind of in the base of the tongue. And that unfortunately did find an oropharyngeal squamous cell carcinoma and P16 positive, which is our kind of surrogate marker for HPV. In these terms, kind of a good prognostic marker. Undergoes multidisciplinary review, and we ultimately decided on chemoradiation. And so far, good response with no recurrence. We're done, right? We move on, we carry on. Good wish. Because of her risk factors, she gets low-dose CT lung screening. And we see that this nodule at the very base of her left lung is kind of increasing in size. So this undergoes biopsy, and based off staging, very limited disease. Fortunately, they undergo surgery up front. And because of some high-risk features, we end up getting 4 rounds of chemotherapy. Now we're done, right? This one's hard to see. So, and part of this workup of the lung cancer actually instantly identified some nodules in the breast as well, left and right. So this is the MRI, which is kind of hard to see in the sequence, but showing kind of enhancing lesions in both left and right breast. These were both kind of sequentially biopsied, and here we have, again, kind of our common ER/PR, so hormone-driven breast cancer, HER2 negative, one invasive, one kind of in situ disease. These undergo kind of a complex sequencing, which will show in a little bit of neoadjuvant anti-hormone therapy, and then surgical management. And so far, completed radiation, and now we're done. Now so far, we're back on surveillance. But here's kind of that complicated picture of how this kind of all goes out. So busy slide. We have this kind of early on diagnosis of the head and neck cancer. We have about 3.5-year latency, followed with ENT labs, no extra imaging at that point other than direct visual examination. And then we have this very busy time when we're trying to narrow down exactly what's going on between mammograms, the CT, and very careful planning with a big team of surgeons, radiologists, medical oncologists, and radiation oncologists to get a plan for this patient that's kind of personalized what's going on. So that was more or less drawn out for about a year when we think of all the modalities of treatment. Now, is there anything in the guidelines we have to guide us on this and tell us what to do? Unfortunately, not. So let's talk about these MPMs. Not a new term. Looks like somewhere around the mid-1800s where it was identified, mostly attributed to surgeon Dr. Milroth. And there were others at the time kind of giving case reports and noticing this phenomenon. But if we look at the definition, we talk about separate cancers that present a definite picture of malignancy with the possibility of one being metastasis or recurrence being excluded. So you're doing all the work to say, is this truly all linked? But you really are trying to rule out that possibility. Officially, more recent, just the last 20 years, this has now moved into an actual category that's been followed by our SEERS data. So tumor registries are now reporting these. And these do include very much malignancies from all tissue types. And I was questioning whether we're going to have something like a basal cell, squamous cell, cutaneous cancers, because oftentimes we kind of push those aside, but those are included in these registries as well. So those that we think are very easily treated with local treatments and curable, they are still included. So patients can have multiple primaries and meet that by having basal cell, squamous cell plus another invasive disease. Two areas that we look at, we have synchronous and metachronous. So synchronous being those that show up within kind of a 6-month window of the first diagnosis. And then the separate one being kind of, you have your first diagnosis, your monitoring, then develops 6 months later. Why that matters is because we can look at the risk factors. We think of synchronous, meaning there's been some exposure. We think tobacco smoke is often the first one we think about. Our veteran population might think of where they're at around burn pits. It might be Agent Orange, it might be some of the other environmental occupational hazard. Kind of a whole body, a whole field effect then develops, maybe months or maybe years later, to kind of have a close development of cancer. Activists can still have those exposures, but then we add on the things that we do, whether interventions between surgery, our chemotherapy, or other systemic agents, and then radiation that then might prompt those cancers to develop later. One study took everyone referred for genetics, being that a lot of those might be at risk for multiple primaries at the University of Miami. And this ended up being about 3,000 patients that they kind of did a retrospective look at the risk factors. This is just highlighting those who had an identified hereditary cancer syndrome, so a pathologic variant in a gene linked with cancer, and then they looked at the rest that were essentially negative on the screening count they had. Between the two is about 20% had a identifiable mutation, and the rest, about 80%, did not. So we still have a lot of factors are unknown. So not that single gene telling us with watching us. So if we look between the two, the kind of timing and rates of these first, second, third malignancies don't really vary much. So they around age 57 was the first, and it's about every 3 years after that they kind of develop their third and second and third malignancy. Same group look at 3 kind of environmental or social factors, trying again see if there was differences. If they did have a identified gene that linked their cancer, was there overwhelming evidence that either metabolic disease, smoking, or alcohol use was maybe a potential risk. Small numbers, but essentially they did not see a strong enough signal to point to, use BMI for metabolic disease. Probably brought up a lot of complications, but that's the information that they had. Smoking and sensitive factors, and then alcohol, which is always reported accurately in medication. But really did not see, at least in these factors, that the kind of these other social and environmental things led to a good explanation for the multiple primaries. Probably really small to see, and that's partly intentional. So this is kind of looking at kind of pooled data of literature out there from other groups that have looked at cancer patients with multiple primaries. Some have nice longitudinal studies looking about every 5 years to see the rates of cancer diagnoses. These are mostly Westerns. We have US, Canadian, European, and Australian studies, but pretty sizable. We can see that quite a range of the rates of multiple primary malignancies, between 2 and 17%, depending on the study. One of the things of having this longitudinal, as patients are living longer, we're capturing more and more malignancies. So sorry to say, if you live long enough, you might live long enough to develop one or more cancers. With this, our SEER data kind of matched that as well. We started collecting data back in 1971 and then doing our iterations about every 5 years of cancer data. We can see that early on when we looked at cancer survivorship, about 50% was kind of average. This is taking all comers of cancer types, gender, and age. And we can see as time goes on, survivorship's going up. So about a 50% rise, close to about 75%, meeting 5% or 5-year survival. So I don't know who's doing that. I don't think oncology is all the responsible for that. Probably happening more before us. We'll talk a little bit in a bit about, is it decreasing smoking rates? Is it more aggressive management of metabolic disease? And is it better screening, catching things earlier? If we try to narrow it down to which of those cancer types are moving the needle more, where are we impacting or improving the outcomes? We can see things on the right side in blue, kind of those decreases in cancer incidence per year. At the very bottom, we have a couple that are actually increasing in their incidence. So a lot of these are upper GI, so esophageal, stomach, and lung, and their melanoma. And we can see less of an impact as we go down. So this is where I said we like to think that a lot of this is prevention of things we can prevent the first cancer from happening. And then others would be our screening techniques. So identify people who are high risk for, say, chronic esophagitis or gastritis and setting of Barrett's and getting those patients set up for more routine endoscopy. Recognizing those patients who have high risk for lung cancer and getting them in for their low dose CT or talking about it. So it might be why we're having more impact on those lung, GI, and gastric cancers. Melanoma might be one. We've had campaigns for skin cancer awareness and sun exposure precautions. We've made some refinement in our surgical techniques, wider margins, sentinel lymph nodes. I would also like to say oncology's done some here too with our immune therapy really being a hallmark and showing survival rates that we weren't able to see before the development of checkpoint inhibitors. A little bit harder to say why we're losing ground on some of the bladder cancer, pancreas cancer, and endometrial cancer. When we think of two organ systems where we can really screen between, UAs, cystoscopies for bladder, and endometrial biopsies and imaging techniques for endometrial cancer, in particular two organs that kind of give us warning signs between hematuria or abnormal uterine bleeding. Pancreas remains a challenge. Where it sits, our screening modalities are poor, and still understanding risk is a challenge. So we'll move on a little bit to what I could find from any of these risk factors for our veteran population. These factors are multiple, and this includes a little bit what we talked about earlier. Some of those kind of host factors, things you were born with, some things kind of out of your control. A lot of these we don't really develop or understand until we age, and then they present themselves, or sometimes we get a good family history that piques our interest earlier on. Hormonal factors, whether that's kind of hormone replacement therapy, we'll debate on whether those really add to the risk, depending on the study. Looking at, we talked about prior exposure, the things that we're doing to patients between radiation, systemic therapy. Alcohol, we have some clear associations with amount and type and certain cancers. Tobacco, yes, we'll look at the graph of that more. Where you live, how you live, basement dwelling, certain areas, you might have some environmental exposures. Pathogens, we sometimes hard to narrow down who's going to have problems with it or not, but we do have certain diseases. We talked about P16 or HPV net cancers, as well as cervical cancer, and then we see some other rare types of like HBV, Epstein-Barr, kind of nasopharyngeal, and some diffuse large B-cell lymphomas. And occupational will be another big one that we'll talk about with the military, just given the roles that they play, the places they serve. So we'll start with smoking, because that's an easy target. And this is a study a few years back, but looking at kind of veteran and non-veteran populations in this window of time, 2003 to 2007, and kind of looking at how the rates have changed. If we see between the two populations, men and women, veteran, non-veteran, we have about a 5% increased rate of smoking amongst veterans compared to the non-veteran population. If we kind of look at first cohort and where they are, as we go through each, we kind of have a rise and those continue to smoke, and we don't really stop increasing up into this last cohort, up into 89 of rates amongst veterans. As we start to see maybe we're coming down, or hopefully this is the downward trend that we're seeing in the non-veteran population. The bottom line is we still have a younger population who still continues to smoke, so we might be seeing some of these problems develop as we age. And then pulling from the latest data from kind of VA references, these are kind of our locations and exposures that we have linked with malignancies. And see they're kind of varied in what they are, either kind of aerosolized material or exposures by being in proximity of them, possibly where you live, what water you drink, or what you bathed yourself in, kind of cleanup, right? Going in to do a job and not knowing what exactly you're handling or being exposed to. Two things that were used as a weapon of war, as we think about mustard and gases, but actually plus and minus of that is a lot of damage done with that. That actually was the hallmark of how we understood our first chemotherapies, particularly with leukemia, with mustard gas and those derivatives. And then kind of what we see quite often now in this aging population would be the potential downstream effect of Agent Orange, as pervasive as it is in the tissues, and kind of population getting into their 70s and early 80s, showing at these different malignancies. I had to stick to the ones that are out there. There are others that we have, I'm sure, a lot of questions about. Hey, I did this. Is this, explaining what's happening now? And those are really hard to answer in clinic. And I think a lot of times we can say, possibly, it's very possible that the link where you were at, what materials you handled, could help explain it, but it is multifactorial. The one group out of the Midwest and Minneapolis VA took close to 4,500 of the patients who had malignancies, and they kind of took it further to see how many of those had multiple malignancies. So a second cancer was identified about 11.4% of those patients. And if they take those patients and look to see who also developed a third cancer, there we have about 13.8 or 70 patients. So that 70 patients is about just over 1.5% of the whole cohort that they looked at. We showed that graph earlier that we had rates between 2 and 17%. So not perfect to compare side by side, but we're probably somewhere in the middle of that range with this one subset of veterans at 11.4 having multiple primary cancers. I pulled a couple of the pieces of data here, just that were kind of interest, both for these synchronous and asynchronous metastases, looking at where we're catching them at stage. I would often think that if we're catching the first one, we might be getting more of these kind of later stages. Maybe it's not obvious from screening or their symptoms come up and we're finding them that they're already advanced, either in lymph nodes or metastasized at that point. What I was kind of surprised by was that when you look at the practice for the second cancers, we're still seeing quite a few of them found in the late stage, 3 and 4. I guess I would assume that if you're plugged in and you have identified mutation or a cancer, you'd be under screening and we'd be able to catch them stage 1, 2, or we can intervene and have more impact with definitive care. So still, I don't perplexing why we're finding them either develop very quickly or they're showing up at advanced stages even after we know they have had a cancer. If we look at the type of cancer we're finding in this veteran population, then I just cut it off because this list goes on with the very varied amounts of combinations that we can see. So I kind of picked the top 5 of these cancers. We're going to see the first and foremost combination of prostate and lung. I don't know if that's a surprise to anyone here, with kind of our heavily male population, and but that's our high rates of smoking that would have a combination of these 2 cancers. What we also see is that prostate and bladder overall are the 2 that are represented in these pairings as we go down to all the different subsets. But here we have bladder, prostate, and then when we think others, head, neck, lung, kind of again, maybe it's a signal higher smoking incidence. Okay. Here's where we're kind of at the whims of expert opinion and meeting in groups and deciding what to do. So if we have these new imaging findings or a symptom that drives the picture, when do we get worried? When do we start thinking, is this fitting with the clinical picture or is there something more to it? So if we think about if we're having a known cancer and you have imaging 3 years afterwards and a new lesion, that timing is kind of in that area where it'd be more rare to have a metastatic lesion at that time, and you should start thinking, is there a new primary? A lot of recurrences are happening in that first 2 years after we find it and do treatment. So past that time point, you start going, what else could this be? There are other cancer types that have a very quick return. So I think small cell cancers, they respond quickly, they come back very quickly. So if there's anything not quite fitting with the kind of typical progression or regression of disease, then it should be raising a red flag to look further. Imaging can tell you a bit, this is kind of where else are we seeing this? Is this a cancer type that commonly spreads? We think lung cancer, bone, adrenal, liver, brain. Are we seeing it in a different place that makes us kind of question if that's the origin? Also, if we think of tumor burden relative to markers, if you think you're following a prostate cancer patient and you have a PSA that's on the lower end and it's really stagnant, but you have a new lesion in the bone or you have a new lesion in the lymph node, that doesn't quite add up. You could have a transformation to small cell, which should be something to watch out for, and then you'd have to biopsy for anyway, or you might have a second malignancy. If you have kind of advanced stage disease, and we'll have examples of this where you have a single isolated lesion and you're kind of wondering, is this we're kind of on stage 3 or are we really pushing into metastatic stage 4? Because that matters what you're going to offer the patient treatment wise. That should also kind of raise a red flag. Say gastric cancer, you have a single lung lesion. You're going to want to know if that's a lung lesion from lung cancer or if that's truly a metastatic lesion. Some nuances we look at when we get PET scans, it's a functional test that gives us both structural and metabolic activity. We're looking at our hematologic malignancies like lymphoma. We might have low level intensity that might point to, okay, this is a follicular lymphoma, this is a chronic lymphocytic leukemia or a small lymphocytic lymphoma. But then you get that really hot or active node, and you think, could there be a separate process here or transformation? So that's where imaging for PET can kind of help explore more. It might need more biopsies. Probably should need more biopsies so we can treat the patient effectively. And then it's the things that we do. So is there a regimen that we treat the patient with a systemic therapy that's very kind of classically known to cause or induce malignancies down the line? Some of these can be quite early, like months after exposure. Majority of these are going to be kind of years, even 8-10 years later. Same if we think about radiation fields. If we're looking at soft tissue, in the full breast, we have a lot of tissue that we go into, and then the outcome of those later on, if the lesion happens just in that field where the radiation falls. So all these should kind of raise red flag to say I need to look more. If I'm dealing with one problem, 2 or possibly more. So we'll go over some examples. This one kind of threw me off. Older veteran had symptomatic anemia, upper GI blood loss. I was identified to have a gastric adenocarcinoma. Not a great candidate for doing kind of our aggressive definitive management, which would have been chemotherapy and discussion of a gastrectomy. Opted for a more palliative approach. Had a great response, had some improvement in life, improvement in bleeding symptoms, and went on observation after that. And just the routine surveillance picked up kind of hypertension we see in the liver. And we would all assume if we gave a palliative treatment for a gastric cancer, there's a very high likelihood that this is just a metastatic lesion from that gastric cancer, right? We're done. Not so much. In very short time, symptoms were driving this, and hard to see, but this is actually the same lesion that crosses over multiple segments, rapidly dividing even with systemic therapy for geared toward what we thought was a metastatic adenocarcinoma. We can't quite tell from just one single cross section, but liver looks pretty good morphologically. We don't see scalping, no cirrhosis. So we kind of presume this is a metastatic adenocarcinoma. Things don't match up with the way follow-up imaging does and the rapid growth in the single site. We may definitely have HCC, hepatocellular carcinoma, only because we biopsied and found out that the histology is different from what the imaging showed us. And very, very aggressive. This is actually a cancer we were able to offer treatment for a patient out to do kind of comfort measures. More recent example here is a patient who had for years kind of a growing area of his left neck. Smoking history. He was a care provider for his spouse who was on hospice care for ovarian cancer. So probably put his own healthcare aside, neglected some symptoms before presenting to us. What we can see is based around here on the left thyroid, large enhanced mass. We do have some necrotic appearing lymph nodes. And if we ignore the image on the right, you can see early on there's maybe a little hint of something enhancing in the right parietal region of the brain. So with further imaging, we identify a single lesion over the right parietal region, and there is some surrounding edema that's not demonstrated on this sequence. So a biopsy, when these lymph nodes in the cervical chain identified a well-differentiated papillary thyroid cancer. I don't know, I look at that and think of something more aggressive, maybe even a dedifferentiated or anaplastic, especially if we're finding something in the brain. That wouldn't be a normal pattern. That would be down to somewhere around 1 to 1.5% of well-differentiated thyroids presenting with a brain lesion. So something's not adding up. Well, we do the craniotomy and get tissue, and it is indeed a well-differentiated thyroid pathway cancer. But as we go to manage each of these and then try to address the neck, we find out in deep tissue, this is actually another mixed pathology. We have a high-grade squamous cell carcinoma of the larynx. So I think always a quote comes to mind when you see things like this is trust no one. No one's going to present with how they should. So when we look at this, when we go about staging, it's a pretty meticulous process. We get a lot of people involved. So there's going to be maybe different modalities. We might be imaging CT, MRI, PET. We might be doing more because we want to try to characterize these lesions. We might be able to get away with doing imaging to avoid tissue biopsies, which we can do for MRI, CT for some sequences for HCC. We could get some T1 imaging for MRI for things like melanoma. But ultimately, we're still going to end up sending these patients for a lot of biopsies. So whether it's imaging guided or endoscopically or even surgical to try and get answers. A lot of times we're going to be pulling in a lot of people. Our early case with both a head and neck cancer, breast cancer, and a lung cancer, we had ENT involved, we had radiology involved in the multiple breast biopsies. We had interventional radiology for the lung, we had a breast surgeon, thoracic surgeon, we had radiation oncology afterwards, and then the lowly medical oncologist trying to kind of pool it, everyone, keep everyone kind of together from local VA and the community. And this might be helpful to have palliative care involved early, especially if we have these multiple malignancies and some of the more advanced stage. If we're going to go for a definitive treatment, as I showed you earlier, that timeline can be pretty extensive, a lot of treatment. Is the patient fit enough to go through treatment for not just one, but two malignancies? Is there one malignancy that is overwhelmingly more high risk or has a poor prognosis? And does it make sense for the patient and their goals to pursue all these different modalities to try to get an answer? So reach out to Dr. Bollinger to get him early. So these are some things you might question yourself when you're seeing these patients. We create a treatment plan and highlight a little bit about is what is the prognosis for each of these. If we have a metastatic prostate cancer, that's a little bit different from a small cell lung cancer. And same thing with earlier on when we have a lung cancer and a hormone-driven breast cancer. There's one that you might want to be more aggressive about pursuing or offering treatments to, and others that we might have treatments that can help prolong life and control symptoms for years. We talked about it earlier, is the goal curative or the palliative. Might be looking at, again, a sequence of mini treatments if it's curative, if the patient's willing to do that. If it's palliative, could we get by with other modalities that treat the symptoms at that time, but maybe give them quality of life? is there any risk to organ or immediate injury? So we think of, is there obstructing the ureter, bowel? Is there some of the organ function, lung or respiratory distress or respiratory failure? Is that kind of the priority to treat the malignancy, driving that to stabilize them and move on to kind of address the second malignancy or third malignancy later? One way we try to look at this is instead of hitting them with multiple targets or multiple different agents, is there some overlap? So this is kind of where the art of medicine comes into play. It's a challenge to find maybe there's one agent that's been shown to be beneficial in both cancer types. Or perhaps we can be more selective and get a target therapy for one cancer, anti-hormone, and systemic therapy for other, or even just radiation surgery for one, or in systemic therapy for the other, where we can kind of minimize the toxicity to the patient. I went through this pretty quick. I did have an example. I used AI, and I kind of like this example of we feel like we're a little bit John Henry against the machine at times. We're going to toil and we're going to beat this, and maybe there's some use for that machine to help us pull in these kind of rare cancer types or rare diseases to guide us on what might be a appropriate treatment for those patients. So when we look, as I showed you, when we get down, there's very few patients who've had these multiple primary malignancies. I think in clinic we have patients who have at least 5, possibly 6 separate cancer that we're managing. But when you go to look for literature, say, how do we manage this patient with all these cancers? No, you might get a case report or here's what we did, but there aren't big bodies of data to say, here's an expert way to handle or offer the treatment for these patients and how to follow them afterwards. We're kind of moving in a lot of our national guidelines for each cancer type, and then so okay, we're going to do both screening. Maybe we might take them to 5 years, and then you might say, well, after 5 years, we just demonstrated how they can develop second, third, fourth cancer. Should we actually keep them in oncology longer and at least have a pulse on symptoms and be able to do scans and in their labs if needed? So as much as we like to get that 5-year mark, gives them kind of a warm handoff back to the primary, maybe we can't, or maybe we shouldn't. The sequencing of treatments, that's kind of, as I said, art of medicine. That's where we have some leeway on what's best for the patient, what's their goals, and then we're sitting down with our big teams to help guide who's up next. And sometimes we want to have those team meetings because you might get one team kind of I can take care of this, let me do it, but that's not the next step. That seems the most appropriate for the patient. So I did want to give an example of this. I don't have it down. There was a patient before coming to the VA that presented with a fairly advanced breast cancer, ended up being hormone driven and HER2 positive. So what we call triple positive breast cancer. So in that staging, the patient was also a smoker, but we happened to find a pretty sizable lung mass as well. So now we have a fairly aggressive histology breast cancer that was also node positive, and now a sizable, ended up being a non-small cell lung cancer, adenocarcinoma, no driver mutations, so nothing we can target with that specific drug. And then we go, how do we sequence a treatment for this? So this is actually a question I asked AI to put in, went to ChatGPT specific and said, how would you take care of a patient with a triple positive, node positive breast cancer and a synchronous stage 2 lung adenocarcinoma? Actually, was pretty impressed with the outcome. It differed a little bit of what we ultimately did, but the nuances that it picked up that it said we have kind of 2 aggressive histologies, and how do we take care of each one in a way that can still offer a definitive or curative intent? And I went through all the different, we need to confirm the histology, we need to confirm the staging, we need to look at cardiac toxicity if we're talking some HER2-based therapy. But ultimately, I think the path it gave me was starting some systemic therapy, chemo HER2, moving to lung cancer treatment with surgery, completing the course of chemotherapy afterwards, healing from that, then addressing the breast cancer through surgery, radiation, and then adjuvant therapy. We're pretty close to that. So what we did for this particular patient was had everyone involved, breast surgeon, thoracic surgeon, radiation, and radiology up front. Actually sent the patient to thoracic surgery first. So they had their lung resection, central lymph node dissection, identified, yes, high risk. This is a patient I would recommend doing adjuvant chemotherapy. That adjuvant chemotherapy for lung had a lot of overlap with the regimen that I can pick for the HER2 breast cancer. So Taxotere, carboplatin, so a platinum-based drug, taxane would be a common combination we would do for lung. There's also backbone that we would use for a combination called TCHP, so chemotherapy plus HER2 before the surgical management of breast cancer. I don't know, at least I was pretty clever at the time, and the patient did well with both, did ultimately get down to her breast surgery, radiation, and then adjuvant therapy, and continues to do well. But I thought, the modeling did well with this kind of rare, how do you handle those two kind of complex and very aggressive cancers? So maybe it has a role in bringing that into these multidisciplinary discussions. They help kind of guide and kind of build from there, since we otherwise lack a consensus on what to do. So summary, we've done a lot. There's some improvements in prevention, our screening efforts and treatment, finding that we have more cancer survivors. Patients either living with their cancer or living cancer-free or remission. We do know that there's genetic pathologic variants out there that lead to cancer, but we also know there's a lot of other factors, and we probably don't fully understand those that lead to why we develop multiple primary cancers. We do know there's some unique risk in our veteran population between what we feel is kind of obvious with the rates of smoking and those kind of identified kind of exposures through their training or their deployment. And that, when we find these, it really is a team effort. We need everyone's some involvement and kind of careful and meticulous process to get the patient the best treatment plan. I'm a little bit early, so open up to any questions. So thank you.
The patient before the gastric adenocarcinoma, the solitary ventilation, would an AFP have been useful at the time? Would you trust it? What are your thoughts on that?
Yeah. Tumor markers, right? Is an AFP reliable, or are these other markers, surrogates for getting tissue? This kind of another angle. I think when we commonly reflex and we'll check those markers, but how much weight we put into them is always in question. I think we see a lot of abnormal liver lesions. I think, we're going to get an AFP that's going to match this, and we get a very poorly differentiated adenocarcinoma that actually isn't expression AFP. So if it was high, sure, that would now go, oh, we have this wrong. Now we really should biopsy and have a different histology. But if it's normal, you're still stuck. It's not going to say that's definitely the adenocarcinoma. You still might be going, this is not fitting clinically or radiographically with this disease. You're still stuck in tissue biopsy.
Thank you. That's super interesting. Primary care question. If someone has an HPV associated malignancy, is there some recommendation for any past screening for other HPV? If they are on the top end, should be looking at the bottom.
It's a good question. I don't know if I have an answer to that, meaning going back to our prevention, right? If you find one transmissible disease, communicable, should you be screening the others that they have had exposure to? That's kind of also one of those things that kind of have talked to the patient and their comfort level of having that discussion with their potential partners or exposures. But I think as a prevention, I would want to offer that screening or testing. I don't know if that answered.
Thanks for talking and representing our life together. My question is mostly about like the role of
misdiagnosis and overdiagnosis in this realm. I think that we don't always get the diagnosis right, even when we have tissue the first time. And also, frequently we see things that we're like, oh, is this actually important for us to do something about, or is it not important for us to do something about? And I guess I was just wondering, you can't do a zillion biopsies every time, and we get things wrong frequently, but how do you, as an oncologist, navigate those kind of nuances around misdiagnosis and overdiagnosis of malignancy? Yeah, so the question of, we start finding things, maybe finding too much, and then questioning, do we something for everything we find? What's the significance? And then maybe we go down a treatment path and realize, oops, maybe we had it wrong from the get-go. I think having those conversations with the patient up front that said, this is, even when you explain, I think this is what's going on. This looks most likely to fit with this pattern. And we have that because of your age, how this presented, what symptoms you're having, where we find it, on scans or the vibe, but in certain areas we say, here's what we have that fits the pattern. We do our best to try and confirm pathology, histology. It might be sending it out for a secondary consultative pathology review, kind of send it to an expert or send it to kind of another academic center to have a multidisciplinary review to say, do we agree with this too? So if there's anything in there that says, this doesn't feel right, I'm pretty quick to send those out to try to get that more confirmatory sense of what's going on. But then it's a conversation with the patients that we do this quite a bit. We have carcinoma of unknown primaries. We still have some patients come back and say, how do you not know what this is? Or how do you not know how it's behaving? We'll go, we have our limitations. We can only biopsy so much, like to say we can't biopsy everything. Can't repetitively biopsy everything. That causes harms too. But if you take them along the path and say, this isn't responding the way I expected it to, then you have a pause point. And before you just blindly push on, I think you have to kind of have that stop and talk to the patient and say, we went down this path, we put this label on it. We gave you this, we recommended this first treatment, which we thought was the best for you. And it's not doing what we wanted it to. And we have that discussion at the end to say, what do we want to do next? So always kind of questioning in the back of your mind. I think sometimes we go on with too much confidence and then you get stuck. You tell them this is what it is, this is how it's going to respond, and then you have a moment where, oh no, I set this expectation and now it's not being met. So I'm probably on the side of, I don't know, I give a lot of ifs and buts and before we kind of come up with a plan, get as much buy-in from the patient rather than just coming and going, this is how it's going to be, we're going to do this. And the question of multiple biopsies or imaging and how much, that's up to the patient too. Like, often they'll say, that's okay. I don't need to know. I'm okay not doing this. So I kind of listen to the patient. Anything else? Oh, all right, thank you. Good work.
Obviously, I was about difference. We're not surprised that John Baptist organization was still getting a second. But the treatment work, the internet, it's just got to be like you guys. It's like you had a leg in, he's getting coming late, the bad mood, as you're a long hospital, and the best of the starts that just like, I don't know if that's also there's a let's check over yes, right, virus. So pretty much back enough. So you're good. Yeah.
Yeah.
Oh, yeah, I'll get it.
Just a bit. Where- So. No, well, it's probably a case. Okay. Reservation, I get some mediation. I'm just trying to.